Hello, I'm Vasilios Lampos, an associate professor at the Department of Computer Science at UCL. In this presentation, I will provide a brief overview of our work on digital epidemiology and in particular on the methods we have developed over the years for modeling infectious diseases using online search activity. The presentation will have four parts. First, we're going to introduce the task of predicting flu rates based on web search trends and go through some basic machine learning methods for addressing it. We will then describe methods for transferring these models to locations that have no or limited syndromic surveillance data, and this can, for example, include locations that do not have very well established health surveillance systems. In the third part of the talk, we're going to show how we can use web search activity to develop models for a novel infectious disease with a focus on our work on modeling COVID. And finally, I'm going to provide a brief overview of more advanced models for forecasting disease prevalence that we have developed and are based on neural network architectures. Let's start by introducing the task of estimating flu rates using web search activity data. Here is the main intuition. Web searches can be indicative of the current state of a user, and they could also potentially provide information about the user's current health status. When someone types medicine for flu in a search engine, it is very likely that they have influenza-like illness symptoms. And if we can identify the searches that are most indicative of flu infection and use some ground truth to calibrate their signal with respect to past flu prevalence rates, we can start developing a model of flu prevalence in a population. In this figure, the red line shows the predicted values of flu prevalence in the United States based on a model that uses web search activity data, and the black line denotes the actual flu rates as reported by the Centers for Disease Control and Prevention, or CDC. These particular estimates have been produced by a model known as Google Flu Trends. But what are the benefits of being able to estimate disease rates from web search activity? Thinking about this as a complementary solution to existing health surveillance approaches, such as monitoring visits to GP practices, hospitalizations, or laboratory tests, web search data can provide more timely, more immediate estimates and can offer a broader demographic and geographic coverage. For example, younger adults might not visit their doctor if they have flu-like symptoms, but they may search online for medications. Or people may search for the symptoms instantly, but they may get a GP appointment a few days later. Other benefits are that web search signals are almost unaffected by closure days, such as weekends or holidays, and that these solutions are relatively low cost. Going beyond only complementing existing systems, approaches driven by web search data can be applicable to countries or subregions that do not have an established health surveillance infrastructure and could help in tracking novel infectious diseases in contrast to conventional health surveillance systems that might be slow to adapt to something unknown. We will see examples of all the above in this presentation. Google popularized the paradigm of using web searches to estimate flu rates by developing Google Flu Trends. This machine learning tool or dashboard provided flu estimates for a number of countries worldwide, but in 2015 it was discontinued, potentially because at various points its estimates were quite inaccurate, triggering negative reactions about this approach. The machine learning model behind Google Flu Trends was a logit linear regression model. Logit is the inverse of the logistic function. The input to a logit function is a number from 0 to 1, and the output is unbounded. This nonlinear mapping or kernel allows us to capture nonlinear relationships between variables. Now, in the Google Flu Trends model, P is the percentage of doctor visits due to influenza-like illness, Q denotes the aggregate frequency of search queries related to influenza-like illness, beta 0 is the regression intercept term, beta 1 is the one and only regression weight for this model, and epsilon is independent zero-center noise. So the model predicts the logit of P, that is the logit of the percentage of doctor visits based on some function of the logit frequency of a set of search queries. The selection of the search queries to form variable Q, which is a form of feature selection for this model, was based on a non-conventional algorithm that I'm not going to explain here. This feature selection algorithm did not properly explore the entire space of search query trends and their potentially complex but also rewarding relationships. However, this was not the greatest issue of the Google Flu Trends method. Its main issue was that the grouping of search query frequencies into a single variable does not give the model the essential freedom to differentiate between queries with very distinctive meanings and purposes, as well as potentially spurious queries. That is, queries that may for a period of time correlate with flu trends, but without a clear causal relationship. This could be seasonal search queries or queries about other conditions that coincide with flu. And these issues are exacerbated by when a spurious search query is very frequent in user searches. Let's see an example of this. Here we have compared influenza-like illness rates for the US from CDC with estimates from the Google Flu Trends model for 5+ flu seasons. For each year-long flu season period, we train a different model based on all past data before that flu season. Black color is used for the CDC data, or the ground truth, and red color for the estimates from the Google Flu Trends model. You can clearly see the under and over predictions that are happening. In some flu seasons, such as the one around 2012 that I have circled here, there are quite major errors. For that period, we have computed the impact of each search query in the estimated flu rates. As you can see, a query about a different respiratory condition, namely RSV or respiratory syncytial virus, accounts for 25% of the value of predicted flu rates. This didn't show up in the experiments of the original paper that presented Google Flu Trends because the model at that time was only tested on one flu season, which I would strongly argue is not enough to evaluate an infectious disease model. Models should always be tested on multiple seasons before we can start making any derivation about them. Another important factor was that not all search queries had the same correlation or relationship with the flu rates. Here's an example for the search query, how long is flu contagious? This is its weekly frequency on the x-axis in relation to the corresponding weekly flu rate on the y-axis. The relationship is clearly not linear. Here, for example, it is bimodal. This would be very hard to model with a regression function that groups all search queries in one variable and learns a single weight for all of them. So we chose to go back to modeling this task in the most common way possible, that is to use multivariable regression. The input variables are the frequency time series of search queries. If we have m search queries or variables and consider n time steps for the time series, usually a time step is a week or a day, we then can represent the input space as a matrix X with n rows and m columns. An element in this matrix, say xij, represents the normalized frequency of search query j during the time interval I. The output variable y is the disease rate at each time step. And finally, our goal is to learn a function f that can map matrix X to the sequence of outputs y. If we were performing linear regression, that means learning a weight for each search query frequency time series and an intercept term, and then using them to obtain estimates of disease rates during inference. So, in this early work of ours, we used Gaussian processes, and specifically a composite covariance function which was the sum of squared exponential kernels. Each kernel was focusing on a subset of search queries, a query cluster. Search queries with similar frequency trends were clustered together using the k-means clustering algorithm. In the formulas here, X holds the frequency of m search queries for a specific week of the year and for a specific location, and Ci is a cluster of search queries derived by using their frequency time series. In that way, the model was multivariate as each query was a different input variable, even as a member of a cluster. We could also capture nonlinearities in the data since we were using a Gaussian process, and we could also allow query clusters to be modeled differently in relation to flu rates. Queries were first selected based on their bivariate correlation with flu rates in the training data, then passed to a linear regularized regression function. In particular, we used ElasticNet, which narrowed down the selection to search queries that obtained non-zero regression weights. Then, these remaining queries were used in the Gaussian process model. Further information about Gaussian processes and all the modeling details can be found in the references at the bottom of the slide. This is the figure we've seen before comparing the flu estimates from the original Google Flu Trends model to flu rates from CDC. And here is what happens when our Gaussian process model is applied. The improvements are visibly noticeable. The Gaussian process model reduces the mean absolute error by 42% and improves, as expected, the bivariate correlation between the two time series from 0.89 to 0.95. The Gaussian processes model we have proposed can also output the uncertainty of the flu rate estimate, something quite useful when it comes to the practical deployment of these techniques. The version of the model I just presented did not use any autoregressive component, meaning that it did not use past values of flu rates to inform a flu estimate. In practice, flu rates that are based on doctor consultations or other clinical indicators are being published on a weekly basis by national health agencies. These flu rates are usually reported with a delay of 1 or 2 weeks. So we could incorporate these rates in our model's estimates. In that way, we can combine web search activity-based estimates that have no or minimal delay with previous knowledge from an established health agency that has a delay of 1 or 2 weeks. In our previous work, we did this using a seasonal REMAX model. It has a seasonal component that captures seasonal trends based on past flu seasons, and we can use estimates from the Gaussian process model as an exogenous input. An outcome of our experiments was that modeling seasonality was not always helpful, but the model selection we performed was able to figure out automatically how much this component should be used. Again, many technical details are omitted here, but these can be found in our paper and supplementary material. The seasonal REMAX model further improves the accuracy of our estimates. Here, I have plotted outcomes when we set a delay of incorporating past CDC estimates to 1 week. This autoregressive model results in 27% mean absolute error reduction compared to an autoregressive version of the Google Flu Trends model, and a 52% improvement over the Gaussian process model I've shown before that did not use autoregression. Yet, there was space for further improvement in the previously described models. We need to do a better job in selecting which search queries to use in a model. For example, odd or spurious search queries such as NBA, injury report, or muscle building supplements were still included in the selected web searches. The frequency time series of these queries had a good correlation with flu rates in the training set, and that is why they were selected in the first place. So obviously the seasonality of these search terms and of the flu rates matched. However, that may not always be the case, and including such terms can result in very misleading flu estimates in future models. To address that, we expanded our query selection filters by introducing a semantic interpretation of the text in the search queries to determine which ones may be related to the topic of flu more than others. We did that by using word embeddings. Word embeddings are vector representations of words. To obtain these representations, in our work, we used an early language model method known as word2vec. We averaged across the word embedding representations of the words in a search query to obtain a query embedding representation. We then generated a way to rank search queries based on how their embeddings were related to a topic about flu. And finally, we combined the semantic ranking with how well each search query's frequency time series was correlating with flu rates. Here I provide a few more details about filtering search queries using a now primitive and not very large language model. On the top of the slide, we have the semantic similarity function that we use to rank search queries based on how close they are to a concept about flu that we have generated. The flu concept is made of two subsets of terms, one providing a positive context and another providing a negative context. A positive term for the concept of flu could be the word flu itself, or a very common symptom such as fever, whereas a negative could be the word Bieber, as Bieber fever was a common expression at the time we were working on this, or Ebola, as this is a different infectious disease with similar symptoms. All context terms or engrams are represented using word embeddings as discussed previously. So imagine we have a search query and we want to compute its similarity to a concept that is made of positive and negative context phrases. The similarity score is equal to the sum of the cosine similarities between the word embedding of the search query and the word embeddings of the positive context phrases divided by the equivalent sum of cosine similarities between the query and the negative context phrases. Here are a few examples taken from our paper. It might be helpful to add that word embeddings were trained using Twitter, now X. This allowed us to capture more informal language, and we actually concluded that learning embeddings this way improves the performance of our flu estimates as opposed to using Wikipedia to train embeddings. So here, in the first row of the table, you see a positive context made of the terms hashtag flu, fever, GP, hospital, and so on. A negative context made of Bieber, Ebola, and Wikipedia, the latter as a way to disambiguate between searches seeking for a general encyclopedic information and searches from people with an infection. The search query called flu medicine was ranked at the top, meaning that it had the greatest semantic similarity score. Flu aches was second, and so on. Although we had to formulate these contexts by ourselves, further experiments showcased that as long as a context was reasonable enough, the finer details, such as the specific choices of positive and negative terms, did not significantly affect the prediction accuracy of the model. Now let's see some evidence about the benefit of filtering queries based on their semantic similarity. Here you can see the flu rates as reported by the Royal College of General Practitioners in England for 3 flu seasons. Now, if we only apply a correlation-based feature selection, we get this. So, what happened in the very beginning where we have a significant overestimation of flu rates? Some queries about a specific individual correlated with the rate of flu in previous flu seasons and therefore were selected by the correlation similarity. These queries severely affected the model. Of course, there were more spurious queries still affecting the model. For example, queries about gaming, queries about the flu vaccine, and so on. So although the model is quite accurate most of the time, there is a moment of significant inaccuracy. By combining correlation-based and semantic filtering of search queries using a hybrid feature selection scheme, we managed to remove most of these spurious search queries and actually improve the accuracy by 12.3% in terms of mean absolute error. So our revised feature selection not only removed the inaccuracy in the beginning, but also improved all our flu estimates on average. The UK's Health Security Agency, formerly known as Public Health England, evaluated this model and decided to include our daily estimates in their flu surveillance reports that are published online on a weekly basis. We refer to this model or dashboard as the flu detector, and you can browse it online. So the first takeaway message from my talk is that we can estimate flu rates based on web search activity, but we need to be somewhat more elaborate compared to the original Google Flu Trends model. Going back to the motivations for this kind of research, I mentioned that web search-based models could be applied to locations that lack an established health surveillance infrastructure. But for the approaches I have presented so far, ground truth data in the form of epidemiological reports of disease rates are essential for training models. However, if a location does not have an established health surveillance system, this data does not exist and the previously presented models cannot be trained. So in the second part of this presentation, we're going to see how we can obtain a disease prevalence model based on web search activity data in the absence of ground truth. In the interest of time, I'm only going to provide an overview and not an in-depth explanation of the methods, and if you're interested, this is provided in our paper. The method that I'm going to describe is categorized as a transfer learning method. Transfer learning methods gain knowledge from a source domain or task, and then they apply or transfer this knowledge to another target domain or task. That helps us obtain models for domains or tasks for which we don't have a lot of data or samples to learn from independently. Here we want to transfer a flu model based on web search activity from a source to a target location. The source location has all the data it needs for this task, web search activity, and the corresponding flu rates. For the target location, we can only use web search activity data. So here is a quick overview of how transfer learning works in this case. Let's imagine that our source location is the US and the target location is South Africa. So we first learn a regression model for the US, estimating flu rates from web search frequencies. Then we map search queries from the US to search queries from South Africa. To do this mapping, we combine a temporal and a semantic similarity between the queries of the two domains. The temporal similarity seeks for similar frequency trends between source and target search queries, and the semantic similarity is based on word embedding representations of the search terms, noting that the languages used in the source and the target locations may be different. We also proposed a hybrid similarity function, which was a weighted average of the temporal and semantic similarities. When the query mappings from the source to the target domain are set, we transfer the regression weights from the source to the target domain. Of course, there are various other nuances in our method. For example, one source query may be mapped to multiple queries in the target domain. But again, all these details can be found in the paper. What is important to show is how this works in practice. In this example now, we are using the United States as the source country and France as the target country. We chose France as our target country in this experiment because ground truth data exists for this country, and we can therefore use this data to evaluate the accuracy of the transfer. Here we have plotted the flu rates in the US with black color and in France with blue color as reported by the respective health agencies. You can see that these are not very similar, but not extremely different either. There are temporal differences, different onset or peak moments, and intensity differences during some seasons. So this is not necessarily a trivial transfer. To recap, first we're going to learn a model for the US based on web search activity data, and then we're going to transfer it to France without using any of the flu rate data for France to calibrate the transfer. We trained and tested our transfer learning model during 4 consecutive flu seasons. On the top, you can see a model where the mapping of search queries between US and France is based on the temporal similarity between query frequency time series. Then, there is an improved model that maps search queries based on their semantic similarity. And finally, when we combine both similarities, we obtain a more accurate model that has only minor discrepancies when compared to the ground truth. Here's another example, now using Australia as our target country and keeping US as the source, just in case you thought the choice of France made the transfer relatively easy. US and Australia have almost opposite seasons, and as you can see, flu rates are reflective of that. Here are the results for this transfer task. Again, we observe that the semantic similarity for matching search queries between the source and the target domain outperforms the similarity function based on temporal correlation, and that the hybrid similarity improves model accuracy further. Most importantly, we see that the method works even for a location that has very distinctive flu trends and seasonality. We do have to note here that this is not a perfect model. We might want it to be a bit more accurate, but in the absence of ground truth information, this is good enough as it is able to capture annual flu trends with a correlation that exceeds 0.9 on average. In the third part of this presentation, we're going to discuss how we use web search activity to model the prevalence of COVID. Similarly to the previous example, there were no historical disease rates to train models for COVID, and the clinical indicators about COVID, especially during the first waves of the pandemic, were not necessarily representative of the entire population. We will be using web search activity data obtained from an API known as Google Health Trends. We obtained the daily frequency of search terms for a number of locations. A reminder that the search query frequency is defined as the number of times a query has been issued divided by the total number of searches for a day in a location. As you can see on this slide, COVID had also a distinctive impact on web search behavior. For the first 20 weeks of 2020, the first year of the COVID pandemic, the frequency of search queries that included the term coronavirus is higher or in par with the frequency of common queries about the weather or queries that included the article "the." So there was probably an unprecedented volume of searches about COVID that our models could leverage from. Let's summarize the challenges in modeling COVID using web search activity data. First of all, there is no reliable ground truth, and even if it was reliable, it wouldn't be long enough in terms of temporal coverage to train a reliable machine learning model. So supervised learning models are not directly applicable here. In addition to that, the evaluation of any modeling output will be challenging. Okay, let's assume we're going to develop an unsupervised learning approach without using any ground truth information, since this is either not available or not always reliable. In that case, we need to somehow decide which search terms to use and also try to make sure that our model is more related to COVID infections rather than other infectious diseases or the expected public concern about COVID. In our attempt to tackle these tasks, we first needed to obtain a better understanding of the disease. The NHS and Public Health England, now UKSSA, conducted a survey asking COVID-19 patients to describe their symptoms. This survey is titled as The First Few Hundred, and it was actually based on about 400 confirmed COVID-19 cases during the onset of the epidemic in the UK. This survey provided us with an estimate of the probability of symptoms caused by COVID, and we used these symptoms to shape our selection of search queries and the probabilities to weigh the importance of these queries in our model. Cough, fatigue, fever, and headache were the most common symptoms. In total, 19 symptom categories were identified, and all of them are depicted on the slide. Of course, this was the picture we had for COVID-19 in the very beginning and throughout its first wave in the UK. The symptom profile changed with different variants. So this is not the definitive symptom profile of COVID-19, but it is nonetheless what was available to us early on. So based on these symptom categories, we came up with common search terms that could be representative of them. This slide provides some example search terms per COVID symptom category for English-speaking users. Beyond symptoms, we also included a category with core COVID-19 terms, such as the word coronavirus itself, and so on. This helped us to capture more general queries that did not necessarily refer to a specific symptom. We then asked native speakers from different countries to come up with search terms that could capture the same symptom categories but in a different language. That's not necessarily a direct translation of the English terms because searches don't always transfer that way between different languages. Here's an example for the Italian language. We use these terms to model COVID-19 in Italy. In total, our study considered 8 countries: the United States, UK, Australia, Canada, France, Italy, South Africa, and Greece. With the help of native speakers from these locations, we formed search term lists for the various spoken languages and dialects. Now that we have determined the search queries, we can begin to describe the next steps for developing a simple model for estimating COVID prevalence. We start from the observation that search query frequencies are quite noisy, especially when a search query is not very frequent, and so we first smooth frequency time series based on a moving window of past values. In addition to that, we also perform linear detrending in these time series to remove an underlying trend, as web search frequency time series are often non-stationary. For example, the frequency of the search term headache that I got from the Google Trends website has an upward trend over the years, as you can see here. Then, for each COVID symptom category, we obtain the frequency sum across all its associated search terms on a daily basis. We then apply a min-max normalization to this sum, so each symptom category gets a daily score that ranges from 0 to 1. Then, we use the symptom probabilities for each COVID symptom category from the first few hundred survey as weights and compute a daily weighted score. We also perform the same computation for the past 8 years to obtain an average baseline score for each day of the year. That would be used as a way to inform us how much COVID-19 might have affected our prior expectation for this score, which is based on the frequency of symptom-related searches before the emergence of COVID. We should not forget that web searches might be influenced by external factors such as news media coverage, and so a web search may not always be representative of the health status of a user. This can particularly affect unsupervised models like the one we are developing here. A supervised model can calibrate itself against many confounding search factors. Our proposed solution here is based on the following rather simple idea. If news media content can assist us in forecasting our method's COVID score more accurately than just auto-regressively using the previous score estimates, then the news media may relate to our COVID estimate better than its own previous values, and therefore they might have had a certain influence in our current COVID estimate. Let's see that with a little more detail. Imagine we know the proportion equal to M of COVID-related news for a specific location, and our COVID prevalence score based on web search activity is equal to G. Both M and G are between 0 and 1. Let's now assume that we can decompose the COVID prevalence score G into GP and GC, where GP represents the part of the signal that is due to infections, and GC the part of the signal that is due to something else, for example, concern. Then our aim is to learn a parameter gamma ranging from 0 to 1 such that GP, the part of G due to infections, is equal to gamma times G, and GC, the part due to concern, is equal to 1 minus gamma times G. So, for a period of n days in the recent past, we first learn an autoregressive model that uses the previous two values of our COVID prevalence score to predict the current one. This is the top equation on the slide. From that model, we obtain a prediction error epsilon1. Then, we expand the autoregressive model to include the percent of COVID-related media coverage in the current and previous two time steps. From the expanded model that incorporates the media signal, we obtain a prediction error epsilon2. Now, if the error of the model that incorporates the media signal is greater, then the media signal does not help, and we assume that gamma is equal to 1, which means that our current COVID score from web searches is attributed entirely to infection. Otherwise, we set gamma as the ratio of the two errors, epsilon2 divided by epsilon1. Of course, that's a crude estimation of news media impact, but nevertheless, this helps us to remove some of the media-driven signal. Then our revised COVID score becomes equal to our current score times gamma, with a reminder that by construction gamma is now a number from 0 to 1. In order to model the impact of news, we needed to form a corpus of news media articles. We obtained data from the Media Cloud database that covers a significant amount of news outlets. You see that more than 200 outlets were used for the US, around 100 for the UK, more than 300 for France, and so on. From these articles, we simply computed the ratio of articles that included basic COVID-related keywords in the title or the main text for each of the countries in our analysis, of course. Throughout our analysis from September 2019 to the end of May 2020, we identified approximately 2.5 million news articles about COVID from a total of about 10 million news articles. Here you can see the average news coverage ratio of COVID-related topics across the 8 countries in our analysis for the first 22 weeks of 2020. At a point in time, almost 80% of the news were about COVID, and then, after the first COVID waves, coverage started to gradually decline. And here are the first results that we obtained by performing the previously described steps. For each country in our analysis, we have plotted the COVID prevalence scores obtained from our model with the blue line, and with the black line, the COVID scores after reducing the news media effect. The dashed line shows a historical average of our COVID score in the past 8 years before the pandemic, and for that we also provide confidence intervals. These are denoted by the shaded area. Scores within the historical average are considered to be within expected rates, and anything above or even beyond that is viewed as a potential anomaly caused by COVID or public health interventions to mitigate the impact of COVID. We've also included 2 vertical lines that respectively indicate the commencement of physical distancing and then lockdown measures. In some countries, such as the US, these lines just signify the first application of such measures in a sub-region of the country. During the first COVID-19 waves in these countries, we observe almost exponentially increasing COVID scores under both metrics we have developed, with and without attempting to remove the influence of news media. We also see that the drop in the COVID prevalence scores tends to follow the application of lockdown measures in most of the countries. The UK, however, stands out as an exception. Our obtained COVID prevalence estimates under both metrics have started to decline before the application of lockdown measures. Perhaps that was an indication that lockdown measures were significantly delayed and hence there was already some degree of herd immunity. Plus, the physical distancing measures that were imposed earlier than the lockdown could have been already impactful. The revised scores that attempt to reduce news media coverage effects oftentimes result to altered trends during the peak periods, compared to the blue lines. On most occasions, the initial COVID scores show an increase prior to the ones with reduced news media effects, and that perhaps highlights a somewhat increased concern prior to the actual peak in cases due to the national or global media coverage of outbreaks in other countries. During a period of 14 days prior and after the corresponding peak moment of the raw COVID scores in each country in our analysis, we see that reducing media effects results into scores that are on average 16.4% lower. Outside the peak period, there is a more moderate reduction of about 3.5%. Here we see a comparison of our COVID scores with reduced media effects, represented by the solid black lines, to the time series of confirmed cases denoted by the red dashed lines. Denoted by the red solid line is a shifted time series of confirmed cases, so as to maximize the bivariate correlation between confirmed cases and our COVID score. If we exclude South Africa, as it displays an outlying behavior, perhaps due to a limited testing capacity or demographically skewed internet access patterns, the correlation between our COVID scores and the confirmed cases is maximized, reaching an average value of 0.83 when the cases data is brought forward by 16.7 days. This provides an indication of how much sooner the web search activity models could have signaled an early warning about a COVID epidemic at the national level. It also shows numerically, as well as visually, but both the increase and the decline of confirmed cases are captured by the web search signal. Here we perform the same comparison with the number of deaths instead of confirmed cases. The average early warning increases to 22.1 days, and the safety time series have a slightly better correlation with our scores, from 0.83 for confirmed cases to 0.85 for deaths. This is expected as the date of a death unfortunately follows the date of confirmation that the patient has COVID. If we think that our score better captures population trends, then the increased maximum correlation with the safety signal of mortality is also expected, because mortality in this instance, and especially in the first waves of COVID, was probably a less biased metric compared to confirmed cases. Beyond the unsupervised models, we also used transfer learning to estimate COVID incidence. First, we learned a model for estimating confirmed COVID cases based on web search activity in a source or reference country that has already experienced a COVID outbreak. And then we transferred that model to other target countries that were in earlier stages of the respective epidemics. This approach introduces a level of supervision and could be used to corroborate our previous findings with the unsupervised model. A caveat of this approach is, of course, that it will also transfer the characteristics and biases of the source country, and especially of its clinical reporting system with respect to COVID in the early stages of the pandemic. We decided to use Italy as the source country as it experienced the first major outbreak compared to other countries in our study. In the transfer learning model, we used the search queries from the symptom categories we have previously identified. We then trained a regularized regression model, and in particular an elastic net, to learn a set of weights, one for each query, so as to estimate the daily number of confirmed COVID cases in Italy. We actually learned tens of thousands of different regression models for varying amounts of regularization, exploring sparsity levels from about 5% to 90%, meaning that models could select from 3 to 49 search queries from a total of 54 queries. Then we established query pairs between Italy and its target country. We looked for query pairs within the same symptom category, and we paired the source query to the target query with the greatest bivalent correlation in their frequency time series after identifying an optimal shifting period. We then transferred the weights from the source to the target feature space for all the source models we have learned for different levels of regularization. Our final target estimate was the mean across all these models. Respective quantiles were used to form 95% confidence intervals for our transferred estimates. We started to deploy this model on a daily basis from February 17 until May 24, 2020, training models on increasing source data on a daily basis. This is what the transfer models looked like on May 24, the very last day of our analysis. With the black line, you can see the transferred estimates of confirmed cases, and with the red dashed line, you can see the reported values in each country. With the exceptions of Australia and South Africa, the peak of the transferred signal appears to be approximately 2 to 3 weeks earlier than the confirmed cases. The decrease after the peak is also more pronounced in the transferred models and always occurs after the commencement of physical distancing or lockdown measures. But this is how the transferred models actually looked in practice. Remember that we transferred models on a daily basis, and as we were doing this, the source model and consequently the transferred models were evolving. This is how they actually evolved. It is not always a smooth process, but all in all there were mostly minor discrepancies compared to the final outcome, meaning that this approach could still be a useful model from a health surveillance perspective. And here we can see a comparison between the COVID prevalence scores based on transfer learning with the black lines and our previous estimates that were based on the unsupervised models with reduced news media effects with the red lines. Their average correlation across the 7 countries in our analysis is equal to 0.66, an indication that there are differences between the two approaches. In fact, their correlation is maximized to around 0.8 by bringing the transfer time series 5 days forward on average, highlighting that the unsupervised signal provides an earlier warning and that both signals are much more similar when their temporal discrepancy is corrected. This helps to further corroborate the validity of the unsupervised model that we have seen before. We also briefly examined the relationship between web searches and clinical indicators of COVID to see whether we could uncover anything interesting. To do this, we jointly used the data from the 4 English-speaking countries in our analysis in an attempt to reduce the bias of the clinical endpoints in each country. We also expanded the list of search terms to include terms that are related to COVID but might not necessarily be about COVID symptoms. And I have provided a link to those terms if you are interested to look them up online. We computed the joint bivariate correlations between search frequencies and clinical indicators, and then we also sifted the corresponding time series in order to maximize these correlations. Here are the top positively and negatively correlated search terms when compared to confirmed COVID cases. Search queries about the disease, such as COVID or SARS-CoV-2, are the top correlated ones. Various related symptoms demonstrate strong correlations as well, although the amount of correlation is not necessarily reflective of the probability of occurrence for that symptom. Some examples include the symptoms of rash, pink eye, blue face, and sneezing. Associated behaviors such as staying at home or physical distancing measures are also strongly correlated. On the other hand, symptoms such as vomiting and migraine show a significant anti-correlation. When we shift confirmed cases back by 19 days and deaths by 25 days, the average correlation across all considered web searches is maximized. Here you can see the top positively and negatively correlated search terms with confirmed cases after shifting data to maximize their correlation. You can see more queries on the top to be about symptoms such as dizziness, rash, stomach pain, some queries about COVID-19 testing or potential treatments, but overall we obtain a similar picture to the comparison shown in the previous slide. We then assess the predictiveness of search terms, turning this into a regression task. Using the frequency of web searches in these 4 countries on a daily basis, we now want to estimate the corresponding COVID cases or deaths. We train multiple elastic net models for different levels of model sparsity to reduce the chance of overfitting. And we retrain models on a daily basis, testing always on the next day. We then use the clinical data to identify the best solution at each sparsity level, that is the solution with the smallest error, and we computed the impact of each search term in the best solution at each sparsity level. Finally, we combine all that to come up with the total impact percentage per search term in our COVID-19 estimates. Here are the search terms that impact the regression task of estimating confirmed cases the most, either in a positive or a negative way. You see the percentages of impact. The most impactful search queries are the ones that include the term COVID, which is intuitive given the magnitude of this pandemic. Blue face, loss of the sense of smell, appetite loss, pink eye, and shortness of breath are the top 5 most impactful symptoms with regards to estimating confirmed cases. In addition, queries about masks or holidays are also impactful. And similarly to the correlation analysis, the search queries related to vomiting have a strong negative impact in estimating confirmed cases. The outcomes are similar for the prediction of COVID-19 associated deaths, noting that 2 new symptoms are introduced in the top 5, rash and loss of the sense of taste. Queries about isolating, staying at home, and queries about masks, diagnostics, and holidays are also impactful. Overall, in all the outcomes of the correlation and the regression analysis, we see that search queries about the common symptoms of cough, fatigue, and fever are not among the most correlated or impactful, suggesting that web searches about rarer symptoms may be more informative. We can also see that symptoms such as anosmia or rash are identified via web search activity. And it is important to mention that it will have taken more time to establish the presence of these symptoms via traditional epidemiological analysis. For England, we could compare our models with outcomes from a swabbing scheme used to test for COVID-19 infections. This scheme included people that did not necessarily have COVID-19 related symptoms, and in that way it was offering a more representative estimate of community level spread compared to the confirmed cases or deaths. In this figure, the rates from the swabbing scheme are shown with the red dashed line, and the unsupervised signal with reduced media effects is plotted with the black solid line. We observe that the weekly COVID positivity rates from the swabbing scheme correlate strongly with our COVID score. Their correlation is equal to 0.86. We can also see that our models provide an earlier warning by at least 1 week compared to the swabbing scheme. And given that the outcomes of the swabbing scheme were published with a delay of 1 week, the early warning in practice is equal to 2 weeks. This comparison with a more conventional epidemiological approach provides some further proof of concept for our methodology. Our COVID score estimates were sent to UKHSA on a weekly basis. According to UKHSA, and I'm almost quoting them here, estimates from our models provided important insights into community transmission at a time where conventional surveillance had limited reach due to the fact that testing was restricted to hospitalized cases. UKHSA analyzed the web search models alongside other surveillance systems with the broad expectation that any changes in trends would be first detected through the analysis of web searches and could then be seen at a later stage in more conventional surveillance sources. In the final part of this presentation, we will touch upon a couple of approaches for disease prevalence forecasting, led by my former PhD student Michael Morris and my current PhD student Yushuan Su. We're now moving to a slightly different problem definition. Instead of predicting the current flu rate, we're now forecasting its future value n days ahead. And we're going to use neural networks to model this. While neural networks have been quite accurate in time series forecasting, one issue is that they do not provide a straightforward built-in way for obtaining uncertainty estimates for their predictions. In our work, we are describing a formalized way to do this and evaluate it on forecasting flu rates. We combine what is known as data or aleatoric uncertainty with model or epistemic uncertainty. Here you can see the first baseline model. This is a feed-forward neural network with 2 feed-forward layers and then a Bayesian layer. The Bayesian layer has a probability distribution over its weights. The input includes autoregressive flu rates with a delay of delta days, simulating the practical delay that these may become available by a public health agency, and search query frequencies for a number of search queries for a window of past days. We assume there is no delay for the web search data as they are usually instantly available. The output is the flu rate and its standard deviation forecasted a number of days ahead. Ultimately, the outputs of the model are stochastic, and hence we have to obtain multiple outputs for the same inputs to then derive a forecast as the mean estimate and also obtain its variance. I'm omitting here most of the technical details, and yes, there are many, but these can be found in the paper. Now, this revised neural network replaces the feed-forward layers with a recurrent layer, namely a gated recurrent unit or GRU layer, which is a lighter version of the long short-term memory layer. If you are familiar with recurrent neural networks, you already know that the input is now a sequence and it does not need to be flattened as it was the case for the previous model. The rest operations of the network remain the same, and this forms our second baseline. And finally, this is an iterative RNN or iRNN, the main model we are proposing. This is a fully autoregressive neural network. The network not only predicts the target variable, but it also predicts all the input data for the next time step. Therefore, this model does not have a fixed forecasting horizon. On the slide, you can see how the network unrolls through time and the provisions we have made for the initial time steps, where some of the data could be known to us and therefore we do not need to predict them. A limitation of the iterative RNN is that ultimately it becomes unaware of the forecasting distance and does not use that to calibrate uncertainty. However, as you will see in the next slides, its uncertainty is sufficiently calibrated and it outperforms other models. Here we provide a comparison of forecasting accuracy for the three neural networks just presented, the feed-forward, the simple RNN, and the iterative RNN. CRPS, or the Continuous Rank Probability Score, is used as a metric that, although has the same units as the mean absolute error, also penalizes the accuracy of the estimated confidence intervals. We also saw mean absolute error and the correlation with the ground truth. Gamma denotes the number of days ahead with respect to the last seen autoregressive value, that is, the last seen flu rate in the input, and flu rates in the input have a delay of 14 days compared to the last seen web search data. So with respect to the web search data, the forecasting tasks are 7 and 14 days ahead. The specific forecasting task here is to predict flu rates in the US using the time series of search query frequencies. From the table, we see that for both forecasting horizons and under all metrics, the iterative RNN clearly outperforms the two baselines. And visually, here you can first see a comparison between the two baselines. We have also highlighted uncertainty estimates at 50% variance with darker color and 9% with the lighter color. The RNN model provides better performance than the feed-forward, as well as more tight uncertainty, although having consistently tight uncertainty could also mean that it becomes quite uninformative and perhaps inaccurate as well. And the iterative RNN yields even better performance. Here we compare it to the simple RNN, and in the process seems to provide also more meaningful uncertainty estimates. These are the uncertainty calibration plots for the three neural network architectures. They show the proportion of the true flu rates that fall within a predicted confidence interval range from 0 to 100%. The diagonal line indicates optimal calibration. Being above the diagonal indicates an overestimation of uncertainty, or in other words, a model that is less confident, and being below the diagonal indicates an underestimation of uncertainty for a model that is overconfident. We see that the iterative RNN is the best calibrated model. The simple RNN is an overconfident model that underestimates uncertainty, and the feed-forward overestimates uncertainty. It is important to note that as the forecasting task becomes harder, as the forecasting horizon increases, we see that the iterative RNN's calibration begins to fail. And this is something that relates to the fact that the iterative RNN is agnostic of the length of the forecasting horizon. We also compared the iterative RNN to a state-of-the-art epidemiological model that at the time had won a recent CDC competition for predicting the rate of influenza-like illness. This model is known as Dante. We had to adjust our training and testing setup to obtain a fair comparison to Dante, and hence you can see that the performance for the iterative RNN here is slightly different to the one provided in the comparison with the baselines. Nevertheless, the iterative RNN outperforms Dante as well. And here is a visual comparison with Dante. An interesting observation is that the iterative RNN may make mistakes by predicting the onset of the flu season earlier, but Dante makes mistakes by predicting it after it has happened, the latter obviously being less helpful. More recently, my PhD student Yushan Su has been leading some very interesting research in advancing deep learning architectures for time series forecasting. She has developed deform time, a quite involved neural network architecture, which is depicted on this slide. It is beyond the point of this presentation to go through this model, but let's just say that deform time uses deformable attention in two parallel modules that we have named as variable and temporal deformable attention blocks in an effort to better capture variable dependencies and their temporal relationship with the target variable. Deform time is a generic time series forecaster applicable to different tasks, not particularly tailored to disease forecasting. Nevertheless, in the next few slides, I'm going to present a small snapshot of its state-of-the-art disease prevalence forecasting results. The results on this slide are for forecasting flu rates in England based on web search activity and are obtained by testing the model on 4 consecutive flu seasons. We also provide comparisons with other competitive models from the literature. We see that deformed time does better across all forecasting horizons. Interestingly, one of the models here, D-linear, does not even outperform a naive persistence model. Do have a look at the supplementary material of our preprint if you are curious about why that might be. And these are the forecasting results for a different location, same setup but different location. The location here is region 9 in the US. This region includes the states of California and Arizona, among other locations. Again, deformed time outperforms very competitive time series forecasting models from related literature. And on this slide we just saw comparisons with 3 methods, but more comparisons are available in our preprint. Finally, if you are wondering how deformed times forecasts look like, on this slide we are showing its forecasts for flu season 2018-19 in England, together with the outputs of various other models. At the bottom right corner, you can see the forecasts of a naive persistence model. It is surprising that many state-of-the-art deep learning forecasters do not deviate much from this naive model. On the other hand, deformed time provides quite accurate estimates for the entire flu season. I also want to highlight here that these results are for 28 days ahead forecasting, a very challenging task in influenza modeling. And with that, I would like to conclude this presentation. One of the main takeaways is that online search activity has a great utility in predicting disease rates. The original Google Flu Trends model might have been a good idea, but the model itself made naive assumptions and was not assessed appropriately. We have provided various modeling solutions that are less prone to this type of errors. We have also shown that these models are transferable to locations that may lack an established syndromic surveillance infrastructure. Moving from supervised to unsupervised models can help us derive models for novel infectious diseases such as COVID-19. And finally, we have briefly shown how advances in deep learning can assist us in obtaining unprecedented forecasting accuracy. Future challenges include further performance gains or starting to understand better what the limits of forecasting performance could be, working on more principled derivations of uncertainty estimates for forecasts from neural networks, and efficiently and effectively combining mechanistic insights from epidemiology within neural network optimization functions. I would like to thank all collaborators who were involved in these research projects throughout the years. I would also like to thank funders for their support. Most importantly, I would like to thank past and present PhD students who led parts of the work that I presented. In particular, Dr. Bin Zhu, Dr. Michael Morris, Dr. Andrew Miller, and Yushuan Su. And thank you for watching.